Hi, everybody. I'm Katherine McDonell. I am one of the neurologists at the Vanderbilt Huntington Disease Center. Thank you so much for having me here today. I'm excited to talk about behavior in HD. We know that behavioral changes in HD can be some of the most challenging symptoms of this already challenging disease, but they are some of the most treatable. And so we'll go through kind of how to understand behavior in HD, how to identify potential triggers for this behavior, and a little bit of how to manage these changes as well. So here's a general outline of what I'll be covering. I'll first give you an introduction to some of the common behavioral changes that we see in HD. I'll go through kind of an overview of the symptoms that we see most often in our clinic. And then we'll go over a general approach to treatment and some tips for how you can manage these symptoms at home as well. We think of HD symptoms in kind of a triad. You might hear us talk about this in clinic or in some of these education days. So in general, the symptoms of HD kind of fall into three basic categories. There are the motor or movement symptoms that you can see visibly. This tends to present as chorea or involuntary movements. HD also causes cognitive symptoms. These tend to be things like slowed processing speed, trouble with decision making, kind of a general executive dysfunction picture. And the third domain are psychiatric or behavioral symptoms. These are often the most burdensome and disabling of the three symptom types for both patients as well as caregivers, but they can also be the most treatable. And that's what we're going to focus on today is kind of how best to treat and manage these symptoms. And this can make a huge difference in quality of life when they are treated well. This is kind of a general schematic of the stages of HD and what symptoms emerge at different time points along the disease course. This is kind of an overgeneralization. This is really variable from person to person. So not everyone will have these symptoms at specific times. But typically you can see that the cognitive and psychiatric symptoms tend to emerge in what's known as the prodromal phase of HD. This is the phase that happens before people typically develop chorea or kind of the visible movement changes that we see as part of HD. And so they typically happen pretty early in the disease course, and they can continue really throughout most of the disease progression. It's common for them to go undiagnosed or misdiagnosed because people sometimes don't understand that they are related to HD, although they are. And we know that there's kind of a combination of biological as well as environmental factors that play a role in these behavioral symptoms that we see. We know that there are, changes in actual brain networks that underlie these behaviors. And then we also know that just growing up in an HD family, kind of living with this difficult diagnosis, brings with it a lot of stress and a lot of kind of social and personal factors that make people a little bit more prone to having these behavioral changes. And so we think they're really related to a combination of kind of both biology and environment. This is a general overview of the types of behaviors that I will talk about today. Again, not everyone will have these symptoms at some point along their disease. Most people will have, some combination of these or some elements of these, but it does not mean that every person with HD will have every one of these. Some people don't have any, some people have kind of a combination. And so the way that HD affects people we know is really variable from person to person, and that also makes it challenging to manage. But these are kind of the most common things that we see in our clinic and kind of the most common things that we're asked to deal with in HD. And so I'll go through each of these in a little bit more detail, and we'll kind of talk through what we see, kind of how they present, how they can look in different people with HD, and then how to kind of best manage them. All right, so we'll start with depression. Depression is something that we see very commonly with HD, with an estimated lifetime prevalence of about 40% of people who will experience depression at some point in their disease course. And they can look really different in different people. We commonly think of depression as looking like sadness or a low mood. They can also look like a loss of interest or pleasure in activities, changes in appetite or weight loss, trouble sleeping, loss of energy, feeling guilty about things, or just kind of feeling worthless in general. trouble concentrating, thoughts about death or suicide, feeling hopeless, and then social withdrawal as well. And a lot of these things, can kind of happen as just part of the disease process in HD. Like I said before, it can be a little bit hard to distinguish what's part of the disease, and what's just kind of a normal reaction to going through some of the really tough stuff that these people can go through. We do a lot of kind of close monitoring of people for depression in our clinic, in order to best recognize these symptoms and kind of get a handle on treating them early, especially when people are going through some tough life stages. So things like deciding to undergo genetic testing, getting results back, going through the death of a family member, or loss of independence, like losing driving privileges, losing a job, things that we know are really difficult for people. We manage depression through kind of a combination of counseling, behavioral therapy. Putting family and social supports in place is also really important. We work a lot with our social work services as well as our psychiatry services, to help kind of set up a kind of multidisciplinary treatment approach for all of our patients. Antidepressant medications can also play an important role and can be really effective in HD. And then we also always want to think about treating any contributing factors. So treating things like sleep problems, substance use, pain, other medical conditions, other things kind of outside of HD that might also make someone struggle a little bit more with depression. So I also want to highlight suicide risk in HD. This is something that we talk about a lot. It comes up, unfortunately, pretty frequently. We know that people with HD, about 20 to 30% of them will think about suicide at some point along the disease course. 7 to 10% will actually make a suicide attempt, and between 5 and 6% will actually die from suicide. And these rates are a lot higher than the rates that we see in the general population, about 5 to 6 times higher. Suicide is actually the second most common cause of death in HD. We know that there are two critical times where that risk is the highest. The first one is at the time when symptoms first start, and the second one is really when kind of loss of independence starts to occur. People lose the ability to work, to drive, to do things that they enjoy doing. And so we are pretty open in talking about suicide with our patients. We do really frequent assessments, particularly again in people who are depressed or kind of going through difficult life stages. When someone does endorse some thoughts about suicide, we try to have a really open, honest conversation to kind of assess, how severe these thoughts are. Have they made any plans or preparation for making a suicide attempt? What are the risk factors that might put them at higher risk of actually going through with those plans? And what are the protective factors that might kind of dissuade them? We spend a lot of time, again, treating underlying depression, treating contributing factors, and trying to assess things that might make people start to have these thoughts. And then we make a lot of referrals to appropriate resources, including social work services, counseling. And then we're fortunate at Vanderbilt to have a strong collaboration with our psychiatry team as well, including a really active inpatient program for people who are in imminent danger. We'll talk about anxiety next. So this is something else that comes up quite a bit in HD. This can be nervousness, kind of excessive worrying, repetitive thoughts, or just kind of a general feeling of restlessness. It can be generalized, so people kind of feel anxious about everything all the time, or situational, in which it comes up in very certain situations, such as doctor's appointments, upcoming events, and things that kind of acutely make people feel more anxious. In HD, it's often provoked by kind of changes in their normal routine, things that are stress-inducing, like doctor's appointments, or things that are upcoming, like a major family event or wedding. And people often can have some social anxiety as well that can relate to the symptoms of HD. So just kind of feeling self-conscious about changes in coordination or balance, changes in speech, things that make people, a little bit anxious about being part of social settings. So in managing anxiety, we focus on identifying triggers and kind of eliminating known sources of stress as much as possible. This is a theme you'll see a lot in this talk, but establishing a predictable routine can be really helpful for people with HD. kind of simplifying choices and decisions, and so they aren't faced with a lot of just kind of open-ended uncertainty. Waiting to discuss things that you know are going to cause a lot of stress until it's necessary. So maybe telling them about a doctor's appointment the day before or the day of, instead of telling them a week before, and kind of giving them all that extra time just to kind of stress out about it. And then medication therapy can be really helpful as well. We treat anxiety similar to how we treat depression. And so medications can often kind of have dual purposes, and can really effectively treat both of these symptoms at once. Irritability is another really common symptom in HD. About 60% of HD patients will have some degree of irritability at some point along their disease. This can range from emotional outbursts, yelling and verbal threats, to really physically violent behavior. And it can be very sudden and dramatic, just really sudden, uncontrollable outbursts of rage. It typically results from some sort of internal or external trigger that you might not even be aware of, combined with an inability to control the emotional response. So just kind of minor daily annoyances can result in this really kind of dramatic overreaction. We see this pretty commonly kind of throughout the disease course in people with HD. So again, you want to look for any identifiable triggers that might contribute to this behavior. You might not always be able to find one, but we always think about things like hunger, pain, frustration. People with HD often have trouble communicating, and that can come up with a lot of frustration and irritability when they just can't really get across what they're trying to tell you. Boredom can also be a trigger, and then again, changes in routine or kind of big stressful events that they're worried about. Again, trying to maintain kind of a calm, structured environment with a predictable routine as much as possible can be really helpful. Practicing de-escalation strategies and walking away rather than confronting someone. And then we do a lot of counseling with our families as well about emergency resources to have at hand in case there are safety concerns that arise. People can become physical sometimes and can become violent. And so having emergency resources to call in those cases is really important to have at hand. And then this is another symptom that is treated really well with medications. This can obviously be really disruptive to family life. And so we do treat it pretty aggressively, and we can actually treat it extremely well with medications and just make a big difference in quality of life for everyone involved. Perseveration is another kind of fancy term that you might hear us use in clinic sometimes. Basically, it means kind of getting stuck on a sticky thought or idea. So people with HD can kind of get fixated on things and come back to the same topic over and over again. This could be becoming kind of preoccupied, again, with upcoming appointments or events, getting really fixated on loss of privileges like driving, or just kind of trivial daily things that you wouldn't really think would be a big deal, but they are to someone with HD. I had a patient who got really fixated on the fact that his wife had gone out and just bought some plants to put around the yard, which seems like a totally normal thing to do, but he didn't think she should have bought the plants. And he would just follow her around the house, for days on end, talking about these plants that he didn't think that she should have bought. And it's a really hard thing for caregivers to manage. It can be hard to kind of get people off this topic. It can be triggered by just almost anything that you wouldn't really think of yourself as being a big deal. And so it can be really exhausting for caregivers who are trying to deal with this. In general, so distraction can be helpful. It can be kind of a difficult thing to do sometimes. It's important to kind of pick your battles and, again, try to avoid confrontation as much as possible. Family counseling can be helpful to identify, situations when this might come up and kind of how best to deal with it within your family. And then frequent breaks and respite for caregivers really can't be overstated. This can be pretty exhausting and pretty tough to deal with. And so just supporting the caregivers is another theme that I think is really important to come out of this, that these people, deal with a lot, and they need breaks and they need self-care as well. Medications can also be helpful for perseveration, so it's also important to talk to your care provider about this. there's often a lot that we can do to help. Apathy is another symptom that is really frustrating for caregivers much more than it is for patients. We typically refer to apathy as kind of a lack of interest and motivation to do things. It can be a loss of enthusiasm or spontaneity, so just not really initiating conversation or not really initiating or completing tasks around the house. People are often just kind of content doing nothing. This is really frustrating and distressing for caregivers, again, often more so than it is for patients. It can look like depression sometimes if people, just kind of want to sit around, not get out of bed, and not do very much. But oftentimes people are just kind of content doing that, and that's one way that you can distinguish. It has been closely tied to disease progression and tends to increase as the disease progresses. And it can again be a really kind of challenging, frustrating symptom. To manage it, again, maintaining a consistent routine can help. Having regular scheduled activities, even if it's just a couple of things per day that people expect that they're going to be able to kind of predict and need to do during that day. Using calendars and reminders, kind of giving people some gentle encouragement to participate in activities. Keeping it simple and focused is really important. So just a few things per day that are feasible for them to be able to do. Avoiding open-ended questions or tasks, so avoiding a lot of uncertainty can also help. And this is also where day programs or in-home caregivers can help as well. People often do a lot more for someone else outside the house than they will for their primary caregiver, which can be frustrating, but it can help kind of relieve some of that burden. And then again, this can coexist with depression. So treating any kind of coexistent mood issues or depression can also help to manage apathy as well. And then obsessive compulsive symptoms are something that we don't see a ton in HD. They're a little bit rare, but they definitely can occur. This can look like preoccupation with germs, excessive hand washing, kind of getting stuck on a really strict schedule that people don't want to deviate from, getting really fixated on certain foods or drinks. This tends to come up a lot in HD where people have kind of a set expectation of what they're going to eat and what they're going to drink at certain times throughout the day, every day. Some people can get a little bit paranoid and kind of start excessively checking locks or windows and things like that. And then collecting items, ordering things online, kind of having to have like a certain collection or like stock of items in their house is something else that we see sometimes as well. These types of symptoms are often managed with medications. So antidepressants can often work well for kind of obsessive compulsive type symptoms as well. Cognitive behavioral therapy is another option that can be really helpful. And then again, kind of treating any coexistent depression or anxiety or other mood symptoms that can often kind of coexist with these types of symptoms and play a role as well. And then finally, delusions and hallucinations are something that we do see in HD. They're a lot more rare than the rest of the symptoms that we talked about, but they definitely can occur. These can include things like paranoia, thinking people are watching you, thinking the neighbors are out kind of watching your house, thinking people are stealing your belongings. Some people have delusions that their spouse is being unfaithful to them or that their family members are kind of out to get them. And then we see hallucinations occasionally. This can include kind of hearing things or seeing things that aren't there. And so in general, with these types of symptoms, it's important to remember that these are absolutely real for the people that are going through this. They're not making it up. You really can't argue with someone or kind of rationalize with them to tell them that these things aren't actually true. Redirection and distraction can help in some cases. And this is another place where medications can be really helpful and can make a big difference in quality of life for both patients and caregivers. It's also important to have an emergency plan in place in case people do get really worked up about their delusions or hallucinations. People can become violent or just really difficult to care for in some cases. So having those emergency resources at hand is also really important if people start to kind of lose touch with reality or just kind of really get engrossed in these hallucinations. Then I finally want to talk about two other kind of behavioral challenges in HD that aren't really psychiatric symptoms, but are kind of parts of the disease that we see pretty frequently that can kind of play a role in the rest of the symptoms that we talked about. So first, loss of awareness is something that kind of pervades HD for a lot of people. This is the kind of the fancy word for it is anosognosia. You might hear us say in clinic, but it just means that people with HD are often unaware of their symptoms. They're not in denial. They just truly do not think they have a problem. And this can be hard to believe sometimes. You can see people with just florid chorea who can't stop moving, or just really problematic behavioral problems, and they truly don't think that there's an issue there. This is really challenging for families and caregivers to deal with, as you can imagine, and it can raise safety issues as well. So for people that really truly think they can still drive or they can still live independently when they can't, this can raise a lot of issues. One thing that can be helpful is kind of focusing not on the symptoms themselves, not saying that you have chorea or you have these movements, but kind of focusing on how they're impacting the person. So they might not be aware that of their movements themselves, but they might be aware that they're dropping things. They can't use their phone or their remote as well as they would like to, or they're tripping and falling, or kind of giving clear examples of how the behavioral symptoms they're having might have interfered with daily life, kind of not let them do things that they would have wanted to do. So you can often kind of get through to people in those ways versus kind of focusing on what the symptoms are themselves that they may not be as aware of. And then finally, impulsivity is something else that comes up quite a bit in these patients. And this is generally kind of having trouble thinking before you act. This can come out in some dangerous or risk-taking behaviors. These can be things like reckless driving, substance abuse, inappropriate sexual behaviors, or even getting involved in illegal activities. These are things that we see pretty early in the disease course with HD, even in like children and young adults who are at risk for HD will sometimes get involved in these kind of difficult behaviors. We think they might be related to kind of some early changes in people's response to reward or self-control. So it's important to recognize these behaviors, to know that they could be part of HD, identify triggers or stressors that might be playing a role in them, provide healthy outlets for people who are going through a lot of stress, and then engaging in safety planning and kind of appropriate supervision to make sure that that these things remain under control as much as possible and aren't resulting in bad consequences. So our overall approach to kind of managing behavioral symptoms in HD, we'll kind of go over some. We've talked about most of this kind of along the way. But in general, being really proactive about screening for these symptoms, including during the pre-manifest period. So before people really have kind of visible outward signs of HD, being aware that these symptoms can happen earlier, and they can start pretty early on in the disease course. And people may not have obvious symptoms and may not even have a diagnosis yet. It's really important to have kind of a team-based multidisciplinary approach to treatment for these patients. And so we're lucky at our center to have really close involvement with social work, with psychiatry, with counselors, and a really kind of a team that can help to manage this. These are often too much to really manage on your own. Family education and counseling can also be really important. Being involved in support groups to kind of talk to others who have gone through similar things can be really helpful. And we rely really heavily on our social workers and the resources that they can provide to these patients and families as well. Behavioral interventions can also be helpful. These are often, again, kind of through psychiatry, so like cognitive behavioral therapy and kind of behavioral modification can also be helpful. And then medication therapy we touched on a little bit, which can be really useful for most of the symptoms that we talked about. The good thing about medications is that there's lots of overlap. And so we can often find kind of one or two medications that can really effectively treat multiple symptoms at the same time. And so we can often kind of target the whole spectrum of kind of what's going on with just kind of a very simple medication regimen. So red flags, again, to be aware of and to not forget about, that really do kind of require emergency intervention would be any physically aggressive behavior, suicidal thoughts, physical threats or thoughts of harming others, and then severe delusions or hallucinations to the point that people are just losing touch with reality and are really difficult to manage. So all these would be behaviors that would warrant a call either to our clinic on-call person or to emergency services who can kind of best direct you into the right route to go to help manage these behaviors. And a lot of these, again, can be really effectively managed on an inpatient psychiatry service, which we're fortunate to have at Vanderbilt. And I think a lot of clinics will have collaborations that can help in these emergency scenarios. So just kind of having a list of phone numbers, having a list of resources, kind of knowing who your go-to people are in case these things come up is really important to have kind of early on. So finally, just some take-home points. These psychiatric and behavioral symptoms are part of HD. They're really common, and they likely result, we think, from kind of both biological and environmental factors. The good news is that they're highly treatable, and effective treatment can really have a huge impact on quality of life for both patients and caregivers that are going through this. It's really important to be open and honest with your HD team. We are here to help. These things are not always easy to talk about, and we understand that. So if you need to kind of pull us aside at the end of the visit or give the nurses a heads up when you first check in that you need to talk about something that you may not want to say, in front of the patient, we're okay with that. Don't be afraid to talk to us. Generally, whatever is going on, we've probably seen worse, and so it's important just to be honest, and we can usually do a lot to help. And again, these things can be really, really hard to deal with. They can have huge impacts on the quality of your life and your family's life. And there's a lot that we can do to help. And then finally, care and support for caregivers are really, really critical. These symptoms can be completely exhausting, draining, really, really hard to deal with. And so practicing self-care, finding ways to take breaks, finding supports and other people that you can rely on is really important. And that's where kind of our social work team can be really helpful in setting up some resources and putting these things in place so you can have a break. And then finally, some resources for more information. So both the Huntington Study Group and the Huntington Disease Society of America have some really great resources on their website for kind of more education and support. The HDSA runs support groups across the country. They also have kind of a centralized links to social work services as well as telehealth counseling services. They have a full information resource library, including a couple of publications about caregiving in HD as well as behavior in HD. And then there are family and community education days like this one, where you can kind of come together and learn from experts and learn from each other on kind of how best to deal with these difficult symptoms. And with that, I'm happy to take any questions. Hey everybody, thank you all so much for listening. Happy to take any questions you might have. Let me just pull up the Q&A box. We've got a few coming in already. All right. So I touched on this a little bit. First question is, what's the best way to bring up concerns about behavior in clinic when they might be difficult to talk about or might make my loved one angry? So this is something that we hear, a lot from our families, that they have these concerns, but they're kind of afraid to talk about them, especially in front of the person who's going through them, especially if they're not really aware that they have these issues. And so we try hard in our clinic to give patients and caregivers an opportunity to talk separately with us. We're lucky that we have a lot of different services that patients often see in our clinic. And so it's pretty easy to kind of separate them out from the caregiver. Someone's seeing social work, someone's seeing speech therapy, and we take those opportunities to kind of check in with each one separately, and kind of see what's going on. Oftentimes patients have things that they want to tell us as well, that they don't really want to say in front of their caregiver. And so we try to give everyone the opportunity to do that. If we don't, you're always welcome to kind of give us a heads up, either before the visit or tell the nurse when you're checking in. Um, sorry. And we will try to give you the opportunity to kind of raise those concerns. And the next question is, do I need to see a psychiatrist or psychologist to kind of manage these behaviors? Um, we do collaborate very closely with our psychiatry colleagues. We manage a lot of these behaviors kind of on our own as well because they do come up so commonly. These are things that you definitely want to see an expert about. A lot of primary care physicians aren't really comfortable and don't have the expertise to manage these behaviors in the context of HD. That being said, we use a lot of the same medications that we would use for other symptoms like depression and anxiety. But I think it's definitely helpful to talk with a dedicated HD team about these symptoms, because we have the experience. We know what works. We know what doesn't work. We know what medications might exacerbate chorea or the other symptoms that are part of the disease. Um, and so I think it's helpful to at least talk with the team about it. We do have close collaborations with psychiatry in our clinic, and so we often will make those referrals if necessary and kind of get you the resources that you need. Do psychiatric symptoms always get worse as the disease progresses or sometimes get better? That's also a good question. This again can be really variable. Like, the rest of the symptoms in HD, um, the way that this affects individuals is hugely variable from case to case. And that's kind of one of the most challenging parts of this, I think. As I mentioned in the talk, a lot of these symptoms do tend to come up early. So they kind of start to emerge in the early prodromal period of the illness. Some of them do get better as the disease goes on. Some of them tend to get worse. But it tends to be kind of a moving target. And that's why we check in with our patients and families really frequently. We typically see people about every 3 months in our clinic, because we know that things can change pretty rapidly. So some things, kind of follow the disease progression. Some things can tend to emerge early. Some things tend to emerge late. And so we try to kind of meet people where they are, and just do really frequent check-ins because things can change pretty rapidly. This is a good question about apathy. Many friends and family members do not feel comfortable talking with our family member with HD because of apathy, because conversation is challenging. We would love to have regular visitors to help with routines. There are also good benefits in socializing, making connections. That is definitely true. I think that is one of the things that can help the most with apathy. Apathy, I think, is one of the most difficult symptoms of HD to treat. It just does not respond very well to our medications or kind of our clinical interventions. And so, kind of establishing those daily routines, kind of figuring out what works the best for your family can really often be the best way to manage this. Um, Getting support from other family members, getting support from, friends, other people who can visit, and kind of break up the day a little bit can be super helpful. Socialization is also really important in kind of keeping your brain healthy, staying engaged, combating, people's tendency to just kind of want to sit on the couch all day. And so bringing in, friends, family members, home caregivers even can be a way to kind of take some of that burden off the caregiver and bring in someone else who can encourage someone, hey, it's time to get up and take a shower. It's time to get up and maybe do some physical therapy. So those resources we definitely use a lot, for these patients to help, kind of combat that apathy in terms of behavioral management. Time for a couple more. Can apathy and anger be early symptoms, or are they more likely after physical symptoms? Anger is a symptom that we really see kind of throughout the disease course. It definitely can come up early. I think it is one that typically tends to start before we see motor symptoms or chorea and HD. That's variable, like I said. But it's not uncommon that once someone is diagnosed with HD, they might bring up the fact that they've had these kind of troubles controlling their temper or their mood for even years, kind of leading up to that diagnosis. And that's something that does tend to happen early. It can persist throughout the disease course. Again, it is very well managed with medications. And so it's important to tell our team about if you are having these difficulties or if your family member is, and we can typically treat it really well. Apathy is the symptom that has been most closely linked to disease progression in HD, and so it typically gets worse as the disease progresses. It can also come up early, but it tends to get worse as time goes on. And so we think of it more as kind of a later symptom in HD than we do some of these earlier kind of behavioral symptoms that we see. All right, we have time for a couple more. Good question about contacting the police department and kind of interacting with emergency services. Someone said they actually contacted their police department in their small town to let them know about their husband, that he had HD and might have occasional episodes, which made it a lot easier if he did have an event one day, that they knew that he had a neurological illness leading up to that. That's really critical. There's a lot of misunderstanding about HD throughout the community, including in our emergency and law enforcement services. And so if you call 911, you don't really know if the person who shows up at your door is going to understand, what HD is, that this is a psychiatric emergency. Someone is not just acting out or, engaging in criminal activity. This is actually a mental health crisis. And so if you are able to engage with police emergency services early to let them know, kind of what is going on and that these are the possibilities. The HDSA also publishes a law enforcement training guide that's super helpful in saying this is what this disease causes. These movements are not voluntary. This person is not drunk. They just have trouble controlling their behavior. In Tennessee, and I think a lot of other states, we also have a mobile crisis line that can be really useful. This is a dedicated emergency line just for mental health services. And so it kind of goes around the police department and sends out someone who's trained in mental health to help kind of de-escalate these behavioral situations. And that can be a little bit more useful sometimes than calling law enforcement if you have access to that. And then finally, our psychiatric hospital also has a 24-hour phone line for crises, which I think a lot of hospitals do as well. If you do have, connections with a psychiatric facility as part of your clinic, it's important to ask kind of what are their after hours policies, what is their emergency plan. We have a separate kind of psychiatric triage emergency department as well, that you can take someone there instead of having to go through the main ED. So this can also be really helpful resources for kind of managing these things if they come up as an emergency. All right, so maybe one more quick one. Finally, someone's asking, if my loved one doesn't have any of these issues, does that mean that these things will necessarily happen in the future? So definitely not necessarily. Again, these symptoms affect people very differently over the course of the disease. Some people really don't have any behavioral symptoms, and that can last kind of throughout the disease course. Some people have a lot. And so it does not mean that, if you're hearing this talking, thinking, oh my gosh, I haven't seen any of this stuff, does that mean that that we're going to be going through this at some point in the future. It doesn't. I think this is meant to be kind of a general overview of some things that might ring a bell with you, some things might not, and it does not mean that necessarily all these things are going to happen. But it's good to be prepared. I think it's helpful to know what can be a part of HD and what is not. So if you do start to notice some of these behaviors, kind of knowing who the right people are to talk to about them, knowing that, this is probably just part of the disease. It's not just this person acting out or, or kind of creating issues. This is part of kind of how their brain is affected. I think can help all of us kind of manage them better. So with that, I definitely want to thank all you guys for your attention. Thank you all so much.